Okay, so good evening to everybody. I think we can start now. I gave us some.
Good evening, sir.
Yeah, how was the midterm?
Very tough.
Very tough, but we did our best.
If you said anything different, I'll be surprised. I know definitely well that even if I bring 1+1, seniors will say it's very tough. It was very, very tough. So, but we will survive. Don't worry. We are good. We are good. Anyway, I want to project my slide for today, and then slides. And please, I hope you have seen them.
No, please.
Please, no.
They were kept on our Telegram page. Have you been there?
Okay.
Yes, please.
Oh, they are there. The slides were the class rep, the Kumasi rep, actually kept all of them there. So check it well.
Okay, sir.
I'm sure you didn't check that one. Anyway, so today we are going to do healing. We are touching on healing, and then hopefully we might be able to finish today. If not, we do want to do that next week. Okay, so when I'm done with this lecture, please, I hope you can see my screen.
Yes, please.
Very good.
Please, yes.
Yes, sir.
Good.
Sir.
Okay. So when I'm done with the lecture, we should have touched on all these things I've listed out here, and then you should be able to answer questions pertaining to these listed 5 points. So we have the processes of healing, patterns of wound healing, factors that influence wound healing, that is both positively and then negatively. And then we have complications of wound healing, and then fracture healing as well. So as I said, we have processes of healing, patterns of wound healing, factors that influences wound healing, that is the positive and then the negative factors. Then we have complications of wound healing, and then we have fracture healing as well. I have a definition for healing, but one key thing you should note is that healing would always follow up on or follow up after inflammatory processes. And so when inflammation is done and then the inciting agent or the injurious agent has been removed, the cells that were damaged would need to be replaced. And that is where wound healing or healing comes to bear. So from my definition, you will see that it is a response to injury following on inflammatory process and comprising of a number of sequentially orderly steps resulting in the replacement of dead tissues or damaged tissues or necrotic tissues. And so when the whole activity of the injurious agent is ongoing, certain cells which were healthy will be affected. And when they are affected, it means that those cells will not be able to perform functions because the effect of those injurious agents will be on the morphology. And you remember I told you that morphology denotes function. And so when there is a challenge with morphology, it will compromise the whole function of the cell. And so when that happens, it means that the cell cannot function appropriately, and then it needs to be replaced or it needs to be changed. And that is where healing comes in or comes to bear. Please remember that in healing, we have what we call the processes of healing. And the processes of healing can be considered in two distinct forms or ways. We have the regeneration, and then we have repair. We have regeneration, and then we have repair. And please note that in regeneration, we are looking at the replacement of the tissue, but then the replacement of the lost one is by similar type of tissue. So let's say that you have the columnar epithelial cells that were damaged. If the cells there are to be replaced by regeneration, then what it means is that at the end of the replacement, we will still find the columnar epithelial cells there. But when we come to repair, where we also call it healing by scarring, or where you have a scar formation at the end of the day, what happens is that we don't have similar type of cell, but then we have what we call granulation tissue. So the cells that were lost will be replaced by granulation tissue. And then it is these, or you have these granulation tissues maturing to become a scar or to form scar. Maturing to form scars. Please bear that in mind. I have a diagram here trying to narrow down and then summarize all that I'm trying to say. So you have tissue that will undergo injury, you have inflammation, then you have removal of dead tissue or injurious agents. And so when you have the removal, that means there need to be replacement. And the replacement would happen by either granulation tissue, where you have the scarring or the fibrous tissue. Then you have the specialized tissue, where you have the regeneration, because of the similar type of cells that will replace the lost cells. Whether by scarring or by regeneration, all of them will end up bringing what we call healing. All of them will bring what we call healing, or will lead to healing. You remember when I was talking the other day, I made mention of, I think it was the cell injury adaptation cell death. Yeah, I made mention of the types of cells we have in our bodies based on their proliferative capacity. And I said that there were three of them. I said we had the permanent, the labile, and then the what? The permanent, the labile, and then the stable cells. That's what I said. In the same vein, because we are talking about replacement of cells and proliferation of cells, we need to still contact the types of cells which the whole body of an individual is made up of, which I told you earlier on are three. So the permanent cells are also known as the static cell population. And remember, I told you that the permanent cell at adult stage, permanent cells cannot undergo cell cycle to produce daughter cells. And I told you that all permanent cells or static cells are either kept enclosed in a bone or attached to a bone. And we said that the cells that make up the brain, that is the neurons or the nerve cells, we talked about the cardiac cells or the cardiac muscles, and then we talked about the skeletal muscles or the striated muscles, striated cells. We made mention of relation. Then we have the renewing cell population. The renewing cell population, where we are talking about labile cells. And I told you that the labile cells, right? The labile cells are always in the cell cycle throughout their life or throughout their adult life. So right from their infancy to their adult life, they will still be in the cell cycle, and they are continuously in the cell cycle. Example of organs that are made up of labile cells: you have the skin, you have the cells of the bladder, right? You have cells of the GIT. Most of the cells that are continuously shed or can continuously be shed, they are made up, most of the organs rather, for which it sheds cells continuously. You would note that the cells are made up of labile cells. They are continuously in the cell cycle. That's because we have already cells that are in the cell cycle to replace the cells that are lost. So shortly after we lose cells from there, they are replaced. Okay. Then we have the stable cells. We have the stable cells, which we also call the conditionally renewing cell population. stable cells, which we also call conditionally renewing cell population. Stable cells, which we also call the conditionally renewing cell population. As its name implies, conditionally. And so unless there is a condition that warrants the replacement of the cells don't go into the cell cycle to produce daughter cells. And I gave you examples of the liver and then the kidney. And I said that they are stable cells there. And then the only time you have the liver going into the cell cycle to produce daughter cells is when you have a damage, when there are liver cirrhosis or some challenges with the liver, right? And then we have lost cells from there. Then immediately the cells that were at the genome stage will now be induced and stimulated into the cell cycle, and then it will proliferate to produce what we call daughter cells. Yeah. Please, any questions so far? Okay, so Albert Krampasaki.
So when we are talking about the liver cells, you made mention example like the skin, and what again? I do not get that point, please. Where we can locate
cells
them.
of the bladder, cells of
Okay.
the bladder, the skin, and I made mention of the GIT. Are we okay?
Yes, please.
Okay. So we move on, and then we would pick, we said there were two distinct processes. We talked about the regeneration and then the repair. So we are picking on the regeneration first, and then later we'll touch on the repair as we progress. So please take note that regeneration is the renewal of a lost tissue in which the lost cells are replaced by identical cells. And when we are to consider regeneration, cells that were left, as in the surviving cells, to replace, that means that the surviving cells are the cells that will go through the cell cycle to produce daughter cells. And so if you don't have surviving cells that are labile cells or are stable cells, then it means that regeneration cannot be possible. Then we also have the migration of the surviving cells into the vacant spaces. That means that the cells would have to detach itself from the existing adhesions of the other cells, so that when proliferation is ongoing, it can also migrate to fill the vacuum or the space that has been created as a result of the injury. So you need the cells to be able to proliferate. They don't need to be permanent cells or static cells. The cells that need to be stable cells or labile cells, and then it must be able to also migrate as a result of the injury. And so note that the capacity of a tissue, right? The capacity of a tissue to regenerate, depends on proliferative ability. It depends on degree of damage to stromal framework, that is the basement membrane, the degree of damage to the basement membrane, and then the type, and then the cells there cannot proliferate. It will not be regeneration. It will not be replacement by similar type. If the damage, maybe the cells there were cells that are labile or stable cells, but then the damage went as far as destroying the stromal framework, or went as far as damaging the basement membrane, right? Then it means that the ability of the cells to regenerate has been destroyed. And so now it's like permanent cells, then it cannot regenerate again unless granulation tissue comes to fill the space and the void. And then the type and then the severity of the damage. The type and then severity of the damage. So remember that if the damage just affects only, let's say, the skin, if the damage only affects the epidermis, we don't have a problem. But when it goes down to the dermis and even the hypodermis, then you know that even though the organ, which is the skin, is actually the cells there rather that make up the skin are actually labile cells. It cannot undergo regeneration because the damage has gone as far as affecting the stromal framework because of the severity of the damage. So please note that tissues formed of labile and stable cells can regenerate provided that the stromal framework are intact. Tissues formed of labile and stable cells can regenerate provided that the stromal framework are what? Intact. Remember that. So if the stromal framework or the basement membrane is not intact and they are damaged, regeneration cannot occur. Now let's consider healing by repair. Let's consider healing by repair. And in terms of healing by repair, right, is the orderly process by which lost tissues or tissue is eventually replaced by scar or granulation tissue. And please remember that a wound in which the lining epithelium is affected heals exclusively by regeneration. That means that if it is labile or stable, and then it's only the epithelium that is damaged, remember that the basement membrane or the stromal framework has the capacity to go through the cell cycle to produce similar cells or daughter cells. But when you have the wound extending to the basement membrane, like I told you, where you have an example of the skin, the damage goes beyond the epidermis, but goes down to the dermis of the skin. You look at that of the GIT, gastrointestinal tract, and then you find the damage going to the submucosa. Definitely in such regard, the replacement will be by granulation tissue. And that is where finally you have scar. That is where finally you have scar. That is where finally you have scar. Okay. So just like I was talking about the fact that if also the cells are permanent, so remember, if there is a damage to the basement membrane or the stromal framework, it will be healed by repair. If the cells that make up the organ are permanent cells, organs like the brain, the spinal cord, the heart, the skeletal muscles, those ones we know very well that they are permanent at adult stage. So no matter what, how the damage is not severe, right, it will still heal by repair, not regeneration. So please bear that in mind. When we consider repair, we know that one key word that I have talked about or made mention of a lot is the granulation tissue. Granulation tissue. And so we have to look at how granulation tissue formation occurs in healing by repair, right? We need to know how. And we have three phases here. We have three phases. We have the phase of inflammation where we are talking about inflammatory processes continues or goes on. You have the inflammatory processes there. That is the phase of inflammation, inflammatory processes. And then this is where, that is with the inflammatory process, that's where you have the polymorphs, because you need the neutrophils, the polymorphonuclear cells, to come and then phagocytose the infectious agents and then the necrotic cells and the debris. So that phase is also captured under granulation tissue formation, because that cannot happen if we have not taken away or cleared or removed the inciting agent or the injurious agent. Phase of demolition. Phase of demolition. Phase of demolition. Where with the phase of demolition, we expect enzymes. Phase of demolition, we expect enzymes. So can they hear me?
Yes,
Yes,
sir,
please.
Yes, sir.
Hello? Can they hear me?
Yes,
Yes,
we can hear you.
Yes, please, we can hear you.
Can you hear? Thank you. Okay, so phase of demolition, this is where we have autolytic enzymes and even proteolytic enzymes that are released. But at the phase of demolition, we expect macrophage infiltration. We expect macrophage infiltration, right? We expect macrophage infiltration. And another name for a macrophage is cells of demolition. Cells of demolition, because they are able to release certain enzymes that have the capacity to break down necrotic tissue or cells. Please bear that in mind. And so these cells ingest particulate matter and then either digesting or removing it. Then we come down to the real deal, which is the third one. I told you we have three phases: phase of inflammation, phase of demolition, and then we have the phase of ingrowth of granulation tissue. Ingrowth of granulation tissue. And here, this is where you have proliferation of what we call fibroblast. You have the proliferation of what we call fibroblast, and that is not all. You have also the growth or the ingrowth of granulation, the ingrowth of new blood vessels, what we call the angiogenesis or the neovascularization. In terms of angiogenesis, you have the budding of vessels as in endothelial cells from existing blood vessels. But in angiogenesis, we are looking at the formation of entirely new vessels. Angiogenesis, you are looking at budding of existing cells, budding of endothelial cells from existing cells. And then you have neovascularization, where you have the entire formation, right, of a new blood vessel. Okay, so please bear that in mind. So in ingrowth of granulation tissue, you have fibroblast, and then you have blood vessels, new blood vessels, ingrowth of new blood vessels, even at the area of injury. Is important because the new blood vessels would ensure that blood supply, which contains oxygen as well as hello. Okay. So we have the ingrowth of new blood vessels, right? And so this is where, as I said, you have vessels budding from existing blood vessels or the formation of new blood vessels. And then is to ensure that blood, which contains oxygen and nutrients, is supplied to the cells there to ensure the repair processes are done on time and then quickly, right? Is to ensure the whole process goes on smoothly and then quickly. We need nutrients, we need oxygen to ensure collagen is laid down and all that. We'll talk about that as we progress. And then we have fibroblasts as well. Fibroblasts actually is very important. The cells that are very important in terms of granulation tissue formation is fibroblasts. And here you have the proliferation and then the synthesis of fibroblasts, leading to the secretion of what we call extracellular matrix proteins. Extracellular matrix proteins. Extracellular matrix proteins. And please note that these extracellular matrix proteins are very much important because they serve as framework, right? It provides or serves as the framework for the proliferation of the endothelial as well as the parenchymal cells. And so here you see that for these extracellular matrices, they are made up of fibronectin, proteoglycans, and then collagen. Extracellular matrix components, you have fibronectin, proteoglycans, and you have collagen. And the collagen, you have the type 1 to type 5. Type 1, 2, 3, 4, and then 5. Please remember that. You have extracellular matrix proteins, which is synthesized by fibroblast. And remember that fibroblast is the key cell that is needed, or that works rather, or that is needed for the ingrowth of granulation tissue. So the whole phase of granulation tissue formation is manned or carried out by fibroblasts with the help of what? The formation or ingrowth of new blood vessels. And I told you that the fibroblast secretes and synthesizes what we call extracellular matrix components. These are made up of fibronectin, proteoglycans, collagen. And please note that with the extracellular matrix proteins, the fibronectin and then the proteoglycans serve as the foundation or the scaffolding for the rebuilding of the matrix that was lost or that was destroyed. And please also remember that when you have fibronectin, which is part of the extracellular matrix components, binding or being bound to by fibrin, it serves as a chemotactic agent or chemotactic factor. And I remember telling you about chemotactic agents when we're talking about phagocytosis in inflammation. Yeah. And we said that you have chemoattractants, endogenous chemoattractants, and then exogenous chemoattractants. And as part of the endogenous chemoattractants, we have C3A, C5A, and all the others we talked about. Yeah. So in the same vein here, fibronectin, when it is bound to or binds to fibrin, acts as a chemotactic agent. And as a chemotactic agent or factor, it recruits or draws a lot of the fibroblasts and macrophages to the site. And the more we have fibroblasts, the more we have the release of extracellular matrix proteins, where you have a lot of collagen, a lot of fibronectin, a lot of proteoglycans as well. And remember that in repair of the whole granulation formation, you need these collagens, you need the proteoglycans, and you also need the fibronectins a lot. Okay. So I have an image here, right, where you have bleeding here. That is where you have the damage, where you have bleeding, you have inflammation going on there, and then cells will begin to proliferate. So you have fibroblast proliferation or proliferating. You have the subcutaneous fats beneath it, right? And then when you have collagen depositions and all that, you will now have your intact epidermis, and then you also have your healed dermis. But then you should expect that you have remodeling that will go on. Remodeling will go on because we don't expect overlaid cells or overlaid collagen fibers there. We don't expect that. And so if you have overlaid, it has to be broken down, or there will be replacement of the existing collagen with, you have the type 3 being replaced by type 1, which has a very strong tensile strength. Okay, so please bear that in mind. Okay, so we look at wound healing proper. And in terms of wound healing, we would focus on the skin, which is actually the archetype of healing, because it contains the epidermis and contains the dermis, and both of them heal separately. Damage to the dermis will heal by repair, but then damage to the epidermis will heal by regeneration. That is why we are saying that is the archetype. The skin is the archetype of healing, so it's considered as the archetype whenever there is damage and healing is going on, or is the perfect example of healing when there is damage to the various layers. Okay, so healing in other organs differ merely by degree rather than of kind. Differ merely by degree rather than of kind. And there are actually two types of wound healing, skin wound healing. Two types. We have healing by first intention, also known as the primary union, and then we have the healing by second intention, also known as secondary union. The healing by first intention, mostly you have the damage happening under certain conditions. What do I mean by that? Most of these wounds we are talking about are surgical wounds. The edges are well opposed. They are closer to each other. There are just less cells or minimal amount of cells that are lost. The whole inflammatory process is less. You don't have a rapid, aggressive inflammation going on. Please so note that. And so all we will need will be just some acute inflammation that will lead to the removal of the necrotic cells, which will also not be much. And healing by first intention quickly takes place under such conditions. Remember, most of the instruments that are even used in creating the wound or the damage is actually being sterilized. Okay. So you come down to the healing by second intention, where you are looking at the secondary union here, also known as the secondary union. But here, the edges are not well opposed. They are not close to each other. The wound is very huge, and it's not under any sterile or clean environment. No, it's nothing like that. And just like we said, you lose a lot of cells. So a lot of cells are lost. From there, you have extensive inflammatory process where you have extensive exudation as well. You have phagocytosis rapidly going on to ensure that there is removal of all these necrotic debris and cells. And please note that whether a wound heals by first or second intention is determined not by the healing process, but by the type of wound. So it is the type of wound that informs us whether this healing will be by first intention or by second intention. So if somebody uses a knife to brandish somebody's hand or head, and then you have a lot of cells lost, such wounds, it will be by second intention. When I pinch somebody or there is a paper cut, even though it wasn't a surgical wound and it wasn't under a sterile environment and the tool was not sterilized, because the damage was just a minor one for which we had less cells lost, and there will be just acute inflammation for which it will not be even extensive and rapid, definitely such wound will heal by first intention. By first intention. Okay. Okay. So we continue. And so we are picking on healing by first intention, and then we are convinced there in some detail, or in some detail. In some detail. In some detail. Please take note of that. Okay. So the incision, that is by first intention, the incision causes death of a small number of epidermal and connective tissue cells without or with minimal damage to adnexal structures. The narrow incisional space is rapidly filled with a fibrin-rich exudate as a result of the increased vascular permeability from inflammatory response initiated by the injury. That is the phase of inflammation. And then you have clotted blood containing fibrin due to hemorrhage from severed blood vessels. And this is where you have the dehydration that would occur to ensure blood clot. And then you have the formation of scab that will cover by the first 24 hours. What will happen? You will still be in the phase of inflammation because you still have neutrophil appearing at the site of injury. You have the release of some enzymes that would digest the clot, heralding the stage of demolition. So here, clearly, you can appreciate that we have the phase of inflammation, the phase of demolition also here as well. Yeah. And so the basal cells of the marginal epidermis, in response to stimulatory factors, will undergo mitosis. When we are looking at labile cells here or stable cells here, it will undergo mitosis. And as a result of that, you have the production of daughter cells. And then the tongues of these epithelial cells from the wound edges will now begin to migrate. Remember, I told you that for proliferation, the cells must be able to migrate. They must be able to proliferate, and then they must be able to migrate into the vacant space. That is for regeneration. They must be able to proliferate. It must be able to migrate to ensure that it fills the vacant space. And so remember that by 48 hours, within 48 hours, what would have happened? Within 48 hours, what would have happened? Within 48 hours, the cells would fuse in the middle so that you have a continuous thin epithelial layer that covers the surface of the wound. I said that it will fuse in the middle. The cells that were proliferated, the cells that migrated will try to fuse in the middle line. And then you find this thin, the cells will be thin layer, and it will cover the surface of the wound. Nanatando.
Hello, sir. Sir, please, I have a question on the first intention and the second intention.
Okay.
My question, you said with the first and the second, it depends on the type of wound. So I was also asking if the area, the surface area that is affected by the wound is also part. As when you compare, let's say, maybe a cut or an abortion to maybe a small part of the body as compared to maybe 2 out of the whole total body. Still be the first or the second, looking at the surface area that the whole thing covers.
It's not only fine, truly it is the type of wound, but remember from the earlier slides, I told you that even the type of cell, do you get a point here? The type of cells that man the specific area is also very important. Please, is he with me?
Yes, I'm with you.
So the type of cells that man the area is also very important. So even though we are looking at the first and second intention, where we are looking at the type of wound, because remember, the type of wound can go as far as affecting the basement membrane, and the healing will not be by regeneration, but then will be by repair. But
Okay.
the quantum of cells that are lost is also very important. If it's just there, no matter how wide the wound is, if it doesn't affect the basement membrane, if it doesn't affect the basement membrane, then we are talking entirely a different thing here.
Oh, okay. Well understood. Thank you, sir.
Always welcome. There are, please let me say this, there are some books you will pick. I think books on surgery, they will talk about by the third intention and all that. Please, in pathology, we only have the first and then the second intention. That's why I've laid that disclaimer there. Don't go and add third intention and whatever. If you are doing surgery and that one calls for the third intention, no problem. But here, we are saying we have just the first intention, we have the second intention. Please bear in mind that. Okay. So we move on. And then by the 72 hours, so this time the wound or the injury. Docas Konu, can you hear me, please? Hello, Docas Konu. Please come back. I want to talk to you. Docas Konu. Docas Konu, I want you to respond.
Sir, please.
Why? What is the problem, please?
Oh.
You have been disturbing the class. I don't know. You are not paying attention, Madam Docas. Please focus, because you know, today somebody called me from I think last year, they did pathology, She called me and she said that she's 50 years, she can't study. What can I do? She trailed the paper. I told her I can't do anything. I don't manufacture marks. I don't do those things. So please, if you don't pay attention and you call me later begging and crying on phone, it doesn't work that way. So please pay attention, Madam Dorcas Kon. If you are not even focusing, put off your mic so that you don't come and disturb us. Okay, so we go on. So we have 72 hours. We have 72 hours here. And then by 72 hours, this time you have neutrophils have largely been replaced by macrophages. Remember, we made mention of neutrophils, and then you have monocytes coming in, right? And then you have the monocytes being transformed to become macrophages. So by this time, you have the monocytes undergoing transformation to replace, transformation to become rather macrophages. Okay. And so this time you find a lot of the macrophages, very, very, very few neutrophils. You have a lot of macrophages, very, very few neutrophils. Please note that. A lot of the macrophages, very, very, very few neutrophils here, and possibly maybe very few or no monocytes, because it is, you have the transformation happening on those monocytes to become macrophages. Please take note of that. Please take note of that. And within the 72 hours, fibrins transcoated by plasma fibronectin, where you have chemotactic factors like I told you about. So you have the chemotactic factors causing the drawing or the calling of macrophages and fibroblasts to the sites. To the site. Remember, I told you fibronectin will bind to fibrin and it will serve as a chemotactic agent. Please bear that in mind. And then it will also serve as a scaffold. We said that the proteoglycans and all those ones will serve as scaffolds to ensure the rebuilding of the matrix. To ensure the rebuilding of the matrix. The macrophages remove cellular debris along the wound margins. And when they do that, because of the demolition factor, it will also secrete what we call growth factors as well. Okay. When that is done, please remember that macrophage growth factors will be released. You have fibroblast, fibronectin, which will stimulate angiogenesis as well. Neovascularization is also ongoing. Remember, we told you that for the ingrowth of granulation tissue, because by this time, it will be healing by second intention. It will be by repair. We are looking at repair here by this time. And so we expect that ingrowth of granulation tissue would occur much, where you have a lot of fibroblasts, you have angiogenesis, and even neovascularization occurring. Yeah. So here you have the solid cores of endothelial cells that will bud or sprout from surviving capillaries there. And remember that because it will not be the three-layered blood vessel, it will only be endothelial cells. It wouldn't be endothelial cells, basement membrane, and smooth muscle. It will not be like that. It will be only endothelial cells. And because endothelial cells have spaces in between them, when blood rushes through that, you see that it will leak into the tissue, and that will lead to edema. It will lead to swelling at that area or that part. Okay. And so, as I said, there will be increase in the inflammatory edema, supplies oxygen that is relevant for metabolic activities, right? And that is not all. Proliferating blood vessels and fibroblasts form what we call a special type of tissue called granulation tissue. So the blood vessel, the fibroblast, they form what we call the granulation tissue. And this is where you have, for those that have been or are at the dressing rooms, those that are at dressing rooms, you see this pinkish substances, tiny granules on the surface of large wounds. Yeah, especially after you've treated, and then after a while, you ask the person to come for redressing. You open up the wound and you see this pinkish. It's actually granulation tissue. The phase of granulation is taking place. That is what it means. And that is where you have this loop of new capillaries that are there. Tiny granules of loop of capillaries. Because there you have new blood vessels, right? You have ingrowth of vessels, and then you have fibroblast as well. Ingrowth of vessels, and then fibroblast as well. Okay. So we come down to day 5. We come down to day 5. And by day 5, you see that angiogenesis, right, or other vessels would heighten by this time. Collagen will be abundant, crossing incision lines to bridge the cut edges. You have the epidermis would have attained normal thickness by now, and then further proliferation of the epithelial cells would cease because we don't more need them. And now, instead of growth factors, we need growth inhibitors, because if it continues, right, it can lead to a tumor. If you still have growth factors, even when you are at day 5, and you have intact epidermis, and you have normal thickness and everything, but you still have growth factors leading to proliferation, it will end up as a tumor. And so by day 5, we expect growth inhibitors so that the whole issue of proliferation will cease. Proliferation and migration will cease. But then you have differentiation of surface cells, which will produce what we call a mature epidermis. A matured epidermis. By the second week, a wound that has gotten to the second week, what would you know? What should you take note of? You have fibroblasts will continue to proliferate, lay down collagen and other ground substances. Maximal collagen content will be reached by about the 3rd week or by this time. And by this time, we expect that by the 3rd week, inflammatory cells and edema as a result of the leakage from the endothelial cells, right? The leakage from the endothelial cells would gradually disappear. Then you have progressive devascularization. So instead of those blood vessels that were formed, they have performed their duties. We no more need them, so they need to regress. Yeah. And so the regression will result in what we call blanching. B-L-A-N-C-H rather, I-N-G. B-L-A-N-C-H-I-N-G. Please take note of that. Okay. By this time, the remodeling I told you about, the remodeling is very important. Remember, I showed you a diagram here. This one. Please, are you with me? Are they there? Or they have left me?
Yes, we are here.
Very good. Very good.
Yeah, we're there.
Okay. Don't leave me. Oh, be there. Be there. Okay.
We won't leave you. We will leave you.
I'm happy with it.
Yeah,
You said the what?
Yes, sir.
Okay.
I mean, the West.
It's not me. You know, I'm not there for you, but unfortunately, that's how it is. It is what it is. Let's go. Okay, so we've gotten, remember, we started with the bleeding, inflammatory cells, proliferation, and migration. Now we are at the remodeling. So I just wanted to make you know where we are now. Okay, let's get back to that place. Get there. Yeah. So the process of remodeling occurs during this period. And so we know that you have collagen type 3 that is laid initially, but that one has what we call a low tensile strength. And so we need, by remodeling, a replacement of the type 3 by type 1, which has a greater tensile strength. which has a greater tensile strength. Please bear that in mind. So acquisition of wound strength slowly occurs with remodeling. Acquisition of wound strength slowly occurs with remodeling. The formation of intramolecular and then the intermolecular cross-links within collagen fibrils. All of them would ensure wound strength. Please remember that. Very, very important. By the first month, 1 month, the wound is now healed and covered by intact epidermis. The dermal appendages destroyed in the line of incision do not regenerate, and then they are permanently lost. The dermis now contains a connective tissue scar devoid of inflammatory cells. And this is it. You have the dermis here. Can you see it? Freshly healed dermis, devoid of any scar whatsoever. Yeah. Devoid of any scar. And please remember that it will never. Lamte, you can talk, please. Rose Lamte, your hand, please.
So please, can you explain the acquisition of wound strength again?
Okay. So what I'm simply trying to say is that when you have the whole healing process ongoing, it gets to a point where, because of the extracellular matrix proteins or components, you have collagen that is laid. Remember, I said that the collagen that will be laid, you have collagen type 1 to even 5, right? And even beyond. But the initial strength of the wound, where you have the epidermis, the intact epidermis, the fact that you have the intact epidermis does not mean that it has regained its strength like before, when there wasn't any damage. So you have the initial strength, which will be the type 3, collagen that will be laid. In such laying, or in such collagen being laid, the wound can easily break again. The wound can easily break again. But when it is replaced by type 1, the type 3 replaced by type 1, now it can bear some weight a bit, even though it would not be as the original. That is why any part of your body where you have had an injury before, even though the place might have been healed, when you apply pressure to the place, you still feel some bit of pain at that site, because even though you have the type 1, which means that it has gotten to its highest tensile strength, it is not still like the original. Lamte, have I been able to help?
Yes,
Hello?
please. But you stated some big names over there, so I thought they play a role.
Is it the collagen type 1, type 3?
Yeah, I think so. The slide before this one, I saw acquisition of wound strength. Then you have some other distance under it.
Oh, okay. Intramolecular and then the intermolecular cross-links within the collagen fibrils. So what
I thought it's explaining the
right?
Okay. So I thought they are explaining the acquisition of wound strength. So
I didn't hear what you said, please.
Please, I thought the intramolecular and then the intermolecular are points explaining acquisition of wound strength.
Obviously, yes, they are add-ups to the fact of the replacement by the type 1, type 3. That's why I was adding that you have the collagen that will be laid, right? The collagen that will be laid, whether it's the type 3 later being replaced, because this intramolecular and then the intermolecular thing will be by the type 1. So you still have an initial cross linkages or the interrelationship of these collagen fibrils with each other. But as I said earlier on, if it is even type 3, which has started the whole intermolecular cross linkages, it will still not be able to bear weight there. It can easily gape or rupture, or you can have the wound breaking.
Thank you, sir.
Are we okay a bit? Okay, welcome. Okay, so where did we get to? Yeah, so we go to this place. So as I said earlier on by the first month, the wound is now healed and covered by the intertepidermis. But remember, I told you, no matter how healed the place is, when you apply pressure, after even many months, you still feel the pain there. You still, when you had not had the injury and healing had not taken place. Okay. Now we have healing by second intention. Healing by second intention, where there is more extensive loss of tissue. Please remember that the steps are similar. The only thing is that this time we are dealing with quantity, because remember that by first intention, we only had few cells that were lost. We had only few cells that were lost. But in healing by second intention, you have a lot of cells that have been lost here. And so quantity difference plays a major role here, causing the whole healing process to be much slower rather than the first intention. Remember, because of the space that was created, what I mean by space is because of the quantity of cells that were lost from that place, a vacuum or a big gap will be created at that part. And even at a point, we have to even consider wound contracture, where you have the myofibroblast playing a huge role to pull the edges of the wounds together, especially when the cells that were lost were too much to the extent that we are not able to replace them. The level of proliferation and the level of even migration is not enough. Then that means that you need myofibroblasts to ensure wound contracture, pull the edges together that way for you. Okay, so remember I said a more intense inflammatory response would happen, and this one will be by repair. So just like I was telling you about the wound contraction thing, a large wound can be reduced by as much as 90% due to wound contraction. And I said earlier that this can only be by the presence and the help of myofibroblast. And I've said it over and over again that when people are amputated, you look at the edge or the surface of the amputated part, and then you see that after some years, it looks like that part has been tied. It's like tie that part like you tie a sack. Looks like that part is actually wound contraction that has happened as a result of the myofibroblast. Okay. Now let's consider factors that influence wound healing. Let's consider factors that influence.
They just begin to form right after wound is completely healed.
It's part of the slides. We'll talk about it.
Oh, okay. Thank you, sir.
When we come to complications of wound healing, formation and excessive granulation tissue formation, and so that is where the whole keloids and even that
okay,
of
sir, thank you.
Comes in. Okay.
Okay, thank you, sir.
Welcome. Okay, so let's look at the whole local and then the systemic factors. Please note that the factors here that influence wound healing, it can influence it for good or for bad. So when we are talking about local factors where we have blood supply, when you have rich blood supply to a site, what it means is that it will fast track wound healing, because the nutrients as well as oxygen that is needed will be available. But when you have areas where blood supply is very slow or difficult to get to, or you have less vessels, blood vessels there, what it means is that injuries to such areas would delay healing to such areas. Healing process will be slow, not because of anything, but because of a challenge with blood supply to the site. Yeah. So you have blood supply being one of them, and I've explained that. Then we have infection. This is considered as the single most important local cause of delayed wound healing. Delayed wound healing. So long as the infectious agent is there, please note that you would have chronic inflammation, rather. You have attempts at healing, right? Active inflammation, and then tissue damage because the infectious agent has not been removed or cleared from the site. So please bear that in mind. And so infection delays epithelial and then fibroblast proliferation, promotes more intense and then prolonged inflammation, like I told you. And so it would not be in our interest if a wound is infected and we are thinking of healing. We have to take away the infectious agent first. That's why we treat such sites to ensure that there isn't any form of infection or infectious agent at that place, so that healing can easily take place and it will not affect the whole proliferation of these fibroblasts and then epithelial cells. Then you have mechanical factors where we are looking at early movement causes mechanical stress of the wound, and then granulation tissue is easily disrupted, and repeated trauma or movement slows the healing process. That is why, as nurses, you know, certain injuries, you don't allow the person to move. We will go and then the leg will be hung up that way. We immobilize the person. We tell the person, don't go anywhere. Just lie on the bed. Have bed rest, and we'll continue with whatever needs to be done until you are okay. The reason is because when you allow movement and stress gets to that site, or weight gets to that particular part, the possibility of rupturing or repeated trauma is very high to the site where there was an initial injury. And just like I said earlier, location of the wound is also very important. Location of the wound. There will be delayed wound healing at where blood vessels cannot be found, or it will go, the location will go hand in hand with blood supply. Because as I said, if there is poor vascularization, what it means is that there will be poor blood supply to the site. Okay. Then we have foreign body here. Delayed wound healing by exciting macrophage response with foreign body giant cells, and then encouraging infection. Remember, we talked about the granulomatous inflammation, chronic granulomatous inflammation. And we said that when you have a foreign body that cannot be phagocytosed, right, what will happen is that the macrophages will now become epithelioid macrophage, and then they will form giant cells, right? And then they will form a wall around it. And I told you that the foreign bodies cannot be phagocytosed. So the only thing is that by just having a surgery to remove the, yeah. So, or if you are dealing with a labile cell, you see that it will come to the surface, and then you can just do incision and drainage, or you can just lyse it yourself. Anyway, which is not a good thing. Anyway, the second one is not a good thing. You have to go to the hospital for them to do incision and then drainage for you. Okay, so we have the next one, which is is actually the size and then the type of wound, the size and then the type of wound. Very important. So large wounds heal slower than small wounds. Large wounds heal slower than small wounds, and we will all bear witness to why it is so, right? Let me see. Let me remember. Lamte, are you there? Is Lamte there?
Yes, please, I'm here.
Why will large wounds heal slower than small ones? Why do you think so?
Because with the large ones, the cell destruction is massive. But with the smaller ones, cell destruction is not massive, so it will have influence on the healing rate.
It will have influence on the healing rate. Okay, that is very true. That because a lot of cells will be lost, we need to replace the ones that were lost. And if they are a lot, then it means that you need a lot of cells to ensure you need a lot of proliferation and then migration to ensure that would actually slow the whole process of healing. Then we have systemic effects where you have nutrition, you have and under nutrition, you are looking at protein deficiency affects acquisition of wound tensile strength through impairment of collagen and intracellular matrix synthesis. Vitamin C deficiency retards wound healing by causing impaired synthesis of collagen, normal collagen. Zinc deficiency has adverse effect on wound healing as metal acts as cofactor of several enzymes. Yeah. Then you have the systemic diseases. There are people that have diabetes mellitus, right? Type 2, and then Otribeti. Okay. So we have people with diabetes, mellitus type 2, and then we have people with Cushing's disease, people with some malignancies, cancers, and all that. When they have injuries, healing is delayed. And there is a whole pathology around wounds, diabetic wounds, and then the whole healing process, the effect of that. Okay. And then we have hormones like glucocorticoids have anti-inflammatory effects and have adverse effects on epithelial regeneration, proliferation of fibroblasts, and synthesis of extracellular matrix. And that will fall under hormones. So all those ones are for the systemic. Let me touch on that. Nutrition, systemic diseases, and then you have hormones as well. When we come down to complications of wound healing, complications borders on two things here. I think somebody asked the question, was it Mohammed that asked that question about keloids and all of that? And so you have deficient granulation tissue formation, and then you have the excessive granulation tissue formation. Tissue. There are instances that the required granulation tissue will be less. That means that it will be less, it will not be enough, or they will be deficient. So, under deficient granulation tissue formation, the result or the effect will be wound dehiscence, the rupturing of wound. And so there are times that people will go and have surgeries, and then abdominal surgeries, and at the end of the day, you can have the best of the abdomen or the rupturing of it due to abdominal pressure. And please note that it is because of the fact that we don't have enough laid granulation tissue at the site. We tell the person, don't call the whole best is inevitable. It will happen. Yeah. And so wounds breakdown or ulceration during healing is due to inadequate vascularization and even the whole granulation tissue challenge, where we talked of the fibroblast ensuring the synthesis of the extracellular matrix proteins, which has collagen in the proteoglycans and then the fibronectins. Remember, so if you don't have enough of that, and that is how come you need the fibrin and the fibronectin to draw a lot of the fibroblasts so that it will synthesize a lot of the collagen and all that is needed. Yeah. And remember that at the earlier stages of wound healing, you don't have enough granulation tissue formation. Possibly you might even be at the stage of inflammation, the phase of inflammation, phase of demolition, and maybe at the initial stages of granulation tissue formation. Easily under such conditions, the wound will rupture or there will be wound dehiscence. But when we come to excessive granulation formation, tissue formation, remember I told you that when you have it being laid a lot, it gets to a point where you need growth inhibitors, not growth factors. You need growth inhibitors, not growth factors. When you have growth inhibitors, it stops it. But in situations where even though we have had enough of the granulation tissue, but we still have overlaid and we have still adding on of the granulation tissue, then what will happen is that we will have what we call a proud flesh. A proud flesh. That is exuberant granulation. And this it will affect what we call reepithelialization. And remember that the excessive granulation tissue formation will lead to the hypertrophic scar. That is where you have accumulation of excessive collagen, giving rise to a raised scar at the site. So this is it. You can have this, the ones up here, you have keloids. These ones are keloids. So you have keloids here, where my arrow is. Keloids here, keloids there, right? These are the first to second or 1 to 2 back keloids, underarm keloids, chest keloids, leg keloids, and all that. All of them are there, right? But what we have here, this one here, is a hypertrophic scar, not a keloid. But note here, when we talk of keloids, we are looking at inherited tendencies to produce what we call excessive amount of collagen. And this happens mostly in blacks, whether they are you must have that gene. There must be, it's actually an inherited tendency. Take note of that. That is why it's not everybody that has it. Okay, so there is excessive fibroblast proliferation. You have collagen production, scar tissue grow beyond the boundaries of the original wound, and then it does not regress. It does not regress, and it forms a dermal mass and then a raised scar. I remember some time ago, I used to do locum at a place when I was done with school. And there was this gentleman that used to come and then buy food around that area. And he was one of these yo-yo boys, you know, those Akata boys. And then he went to pierce his ear. Unfortunately for him, it turned out to not be what he expected. Rather, it led to a growth. There was exuberant proliferation. There was excessive granulation tissue formation. And it was not just a raised scar, but then it ended up becoming a dermal mass, which was a keloid at the ear. Just recently, I went to give a lecture in the university where I'm permanent at, the government university where I lecture at. And then I sat in a car with a gentleman, and the gentleman had a big keloid around the neck region. I think from the ear. Yeah. So those ones are keloids. You have excessive amount of collagen. You have still excessive fibroblast proliferation and even collagen depositions as well. Okay, and it does not regress. Please bear that in mind. Then you have desmoids. The picture I have here at this part is the desmoids. For the desmoids, it leads to recurrence, and you have exuberant proliferation of fibroblasts as well. And please note that it affects other connective tissues. Unlike the keloids here, where you have inherited tendencies, the desmoids are not inherited tendencies, and most of the time the desmoids are covered by the skin. But you can see, sorry, from here, that for the keloids, you have them extending like that. And then it's like they are out of the skin. Okay. And then you have contracture, which I've talked about, where it happens even as a result of some burns, which can lead to deformities, lead to compromised movement of joints. When people have burns and then they don't visit the physiotherapy department for them to help them out, and then there is complete healing, or there is healing, right? The wound heals. Sometimes because the joints were compromised, they were not moved about that way, you see it rigid that way. And then if it has to do with the arm, the person cannot even stretch for the arm, because when they decide to do it, comes with excruciating pain. So we come down to healing of fracture. Healing of fracture. Healing of fracture. Healing of fracture. Please note that for healing of fracture, fracture repair is a healing process by regeneration. So here we are looking at the bone here. And remember that the cells that make up the bone, we have the osteocyte, we have the osteoblast, and you have the osteoclast as well. Yeah, you have the osteoblast that lays down the cells of the bone, and then you have the osteoclast, right, that yes. And then when the osteoblast, which is actually immature bone cell, but then differentiated to perform bone duties, when they mature, right, and then they rest in the lacunae, they are osteocytes. They are osteocytes. Please remember that. There are three phases here. We have the inflammatory phase, we have the reparative phase, we have the remodeling phase also, where the inflammatory phase will last for about 1 week. Reparative phase lasts 6 to 12 weeks. Remodeling lasting several months to years. Remodeling lasting several months to years. Okay. So this is the whole step in fracture healing. Step in fracture healing, where you can clearly see images down here. Happiness. Happiness, your hand is up.
Yes, sir. So I didn't get the part. Osteoclast is involved in.
Osteoclast is considered as the bone destroyer. It's like the macrophage there of the bone. And I said that when then differentiated to perform bone duties, when they are overlaid, the activation of the osteoclast would actually break them down. I don't know if you are with me. That's what I said.
Okay, sir.
Okay. Always welcome. Your name is Happiness what? Ajiji.
Bulu's Happiness Ajiji.
Hello. She has run away.
Yes, sir.
Ajiji. Okay, that's nice. That's good. Okay, so I have Zidofe Ahiabel. I hope I got the name right. Forgive me if I murdered your name.
You've tried. It's Jidefo.
Forgive me. Okay. It's what? Jidefo. Okay.
Yeah. The osteoclast, is it not the one that is meant for the osteoclast, is it not the one that is meant for the remolding of the bone after the healing process?
That is why I said that when you have it overlaid, it breaks the osteoblast, and if breaking it down means remodeling.
Okay.
Because when you have it overlaid, the osteoclast must be activated.
Okay.
And it is actually known in literature that when the osteoclast is activated, it is able to destroy as much as 100 to 1,000 osteoblasts. Yeah.
Yeah.
See, therefore, are you okay? See, therefore,
yes,
are you
sir.
okay?
Thank you.
Okay. Always welcome, please.
Yes, sir. I'm okay.
Okay. Okay, so let's look at the structure here for fracture healing. And then we have hematoma here, right? Hematoma is here. Remember, you have the catabolic phase, anabolic phase is here, catabolic phase here, and the chondral phase here, inflammatory phase starts from here. And you have the coupled remodeling phase or stage, which is also here. But remember, you have the hematoma, right? Where you have the macrophages and the monocytes and all that. And then you have the soft callus, which is unmineralized, the fibrous tissue that will be there. That is not the days. So 0 to 3, 0 to 5 days, there you still have hematoma. And then you have soft callus from the 5th day to the 10th day, which is unmineralized. You have cartilage there. You have either soft callus and then the unmineralized cartilage. You have fibrous tissue here from the 10 to 16, 16 to 21. You have the hard callus, which is the secondary bone, also known as the secondary bone. And then you have the hard callus again, but then it will be coupled with remodeling or remodeled bone. And at the end of the day, you might not find anything that shows that from the 21 to 35 days, we have excess laying there. No. You have osteocytes at this point. So let's go through the steps here. So at the moment of fracture, blood vessels through the Havasian system are torn at the fracture site. And you have local hemorrhage and formation of hematoma that fills the fracture gap and then surrounds it. That is where the hematoma comes in. It forms the scaffolding for granulation tissue. The inflammatory process, which follows immediately after the injury, brings what we call leukocytes to the sites or recruitment of leukocytes to the site. That's the inflammatory phase. Remember, I said that we have the inflammatory phase, proliferative, and then the remodeling phase. Okay. So by the end of week 1, phagocytic cells have been removed, most of the hematoma, and then the neovascularization. Remember, the formation of new blood vessels and initial fibrosis are occurring. By this time, we expect that these proteins, the platelet-derived growth factor, the transforming growth factor beta, fibroblast growth factor, and then the cytokines would activate what we call the osteoprogenitor cells. Like I told you, in the periosteum, medullary cavity, and then even the soft tissue, and stimulate what we call the osteoclastic and osteoblastic activity. So the osteoblast, and I told you the osteoblast is responsible for the laying down of the bone cells. It undergoes the proliferation and the migration. But then when it is remodeling or when it's overlaid, we activate. Can you hear me? I think I went off.
Yes, sir, we can hear you now.
Yes, sir. We can hear you now.
Let me share back and then.
Now, sir.
You said what?
It's better now.
It's better. Okay. I think it went off and then I had to. So let me share again.
No, no, no. What's it? Oh, no, it's on. Everybody will be eating.
Is it visible, the screen?
Yes, please, we can see it.
Yes, please.
Okay. Let me just finish up with this. Okay. So just like I was saying, by the week 2, you have osteoclast activities as well as osteoblastic activities all happening. We expect that there will be differentiation of the soft tissue into chondroblasts, and then there will be the lay down of fibro and then hyaline cartilage. If the fracture is uncomplicated, by the end of the 2nd and then the 3rd week, the fracture site is immobilized by fibrocartilaginous tissue, which is called the soft callus, but not yet strong enough for weight bearing. That is why you have to wait till you are at 2. And then again, you have the newly formed cartilage, which will undergo endochondral ossification, that's mineralization. And then it connects to the newly formed woven bone, resulting in the formation of bony callus. Remember that it is the mineralization of the callus that ensures the stiffness and then the strength, so that at the end of the day, it can be able to bear some weight there. And then during remodeling, the callus, which is laid in excess, is resorbed, and that's what I told you about. And the bone models or remodels on it. So at the point in time when remodeling is to take place, we can allow you hit the gym, maybe use your treadmill a bit gradually, not quickly going to, might be too much, and then you might have another fracture again. So it will be advisable to look at the weight as the strength builds up. Okay. So if the bone ends are not perfectly aligned, we are looking at complicated fractures here, then obviously the volume of the callus must start at a concave level where it starts from the middle. Because if it becomes convex, right, and then a bit of weight is beared on it, the possibility of the fracture occurring again is very high. So please bear that in mind. So the medullary cavity is restored, and after remodeling is completed, it is impossible to demonstrate the site of the healed fracture. Because remember that here, it wouldn't be granulation tissue, but it will be similar type of cell. Okay. We consider the factors that affect wound healing. In the same vein, we have to look at the factors that affect bone healing. So the overall these ones, the bone that is involved, fracture site, the fracture site treatment, where we are looking at the internal versus the external. Yeah, the soft tissue injury. If it was that bad that you had even some soft tissue coming in between the bone, then it means that some surgery must be done at the bone, especially when you try to allow a bit of weight on it. And then the treatment complications as well, and even movement, like I told you earlier on, mechanical stress and factors. So you have movement, you must know when to allow weight or movement or at that site. If you are still at the inflammatory phase or reparative phase, it's not advisable, because it can lead to what we call pseudoarthrosis, false joint. Please, when do you want to see your midterm marks?
He's there.
Sir, even right now.
Let's see.
Today.
Anytime.
You have to give us some exercise to cover up.
Inside. Let me say there. It's not easy.
We play that maybe
Then we have to
Sir,
do
we
backup.
we have to write another one.
Backup.
You have to write another one.
Yes, sir.
You let's continue. Write another one next year.
Sir, please give us a broken heart today.
I should give you some words.
Some cardiac arrest.
A backup.
That's why you wrote assignments. So don't worry. Yeah.
Thank you, sir.
And don't worry. That's why you wrote assignments. And just like I told you the other time, the exam, all of them are coming from where you know it's coming from. So steady work.
So we are in your hands.
Anyway, all 200 questions. Okay, so we continue. So we have the interposed soft tissue. There are instances where, just like I told you, you have broken ends, right? And then you have a tissue, a soft tissue in between the broken ends. And that prevents union. So it will lead to non-union. And just like I told you, there will be the need for a surgeon to come in to help. And then we have misalignments, displace fractures, heal slowly, right? And result in some deformities where it will lead to shortening of one leg from another. And it will lead to even increased risk of osteoarthritis and in even other adjacent joints or in adjacent joints. We have infection. I told you about the whole impact of infection, where it will delay wound healing. It will affect the laying down of collagen and all that. The same way here, when you have an infection, healing will be difficult to take place. Healing will be very difficult to take place. So please take note of that. Then you have comminution. Comminuted fractures frequently result in deformity and predisposed to development of arthritis, osteoarthritis. And remember that we have what we call pre-existing bone disease, just like I told you of the diabetes mellitus and then that of the Cushing's disease and some cancers and all that. When you have pre-existing bone disease, it affects and delays and slows down the whole process of bone healing. Please remember that. We have others like the vascular insufficiency, where blood supply is also another issue here. You have malnutrition, vitamin deficiencies, just like we made mention of the systemic factors. So we have systemic infections, diabetes mellitus, calcium and phosphate deficiencies, and all the others. All of these can affect healing of the bone. Please take note of that. Now we come down to the healing of tendons and then ligaments. We come down to the healing of tendons and then ligaments. Please note that we are looking at dense fibrous connective tissues here, and they are composed of 78% water, 20% collagen, specifically type 1, and then 2% proteoglycans. And remember that these tendons and ligaments are able to bear some load, a lot of load, right? Even in unidirectional tensile loads, they are able to help with the transfer force, provide strong, flexible, and then they help the tissue respond to normal load whilst resisting excessive mechanical and shearing force and deformation. And so remember that we are able to carry buckets of water. We are able to carry them by arms, carry them on the head, and then we are able to stretch those joints as a result of the tendons and then the ligaments. And please take note of that. And note that when we look at tendons, we have them as in muscles, we have them attached rather to muscles, as in you have muscle to bone origins, insertions there. But when we talk of the ligaments, we have bone to bone insertions here. So remember, for the tendons, attaches muscles to their bony origins and insertions, but you have ligaments where it attaches bone to bone, providing support for joints. So this one will be ligament, but the one that would attach, like we have here, this one will be tendon, right? Yeah. This is a tendon. This one is a ligament. Cal repair. Reason is simple because, because it can stretch very much. When it tears or it breaks, you have the edges being zigzag because it would have pulled from each other, pulled from the sides. And so you need to cut the edges and make them equal. Then you can suture them like that. If there are ruptures of such caliber and you are not quick to address it, you can be looking for the tendon and you cannot find it. So it always requires an immediate attention when that happens, so that we can find the ruptured the ruptured tendon or that particular tendon that I would fold and go and hide somewhere. So that we can just pull it and then we can just suture them like that. Okay. So we move on. Remember that we said that you have inflammatory phase would happen. You have the demolition phase would also happen. And then you have migration and proliferation of fibroblasts and then capillary buds from the surrounding connective tissue. Remember that for tendons and then ligaments, you have granulation tissue here, unlike that of the bone where we said that you have replacement of similar type. So you have migration, proliferation of fibroblasts. That means that extracellular matrix components, which would have collagen deposition, is very important. It will be here too, as well. So about 2 weeks into healing process, collagen fibrils are oriented, and this is to help you with the whole tensile strength. And remember, type 3, type 1. And then cross linkages, and then the collagen fibrils, intermolecular, intramolecular thing. Okay. So during this period, immobilization relieves stress and prevents re-rupturing. So during this period, I don't expect you to go and then jump on the treadmill and be running around and then be carrying weights and all that. It can re-rupture. When healing has progressed sufficiently for adequate tissue integrity to be achieved, that is when we allow mobility to help with remodeling like that of the bone. Collagen will realign as the person moves about or exercises. Collagen will realign to the lines of stress provided by motion to its usual parallel arrangement. It will take as much as 40 to 50 weeks for tendons and ligaments to regain normal strength. That is how come most of our athletes that have tendon tear or ligament rupturing, most of them don't regain their strength like before. If they are athletes, they are not able to regain their lost glory. Yeah, they are not able to at all. If they are, they are footballers, it becomes very difficult for them to play at the highest pinnacle they used to play, because it will take that long, and then after that, the strength will still not be like the original one. The strength will still not be like the original one. So the scar tissue formed is weaker and has increased amount of minor collagen, and then you have increased proteoglycans, and then you have decreased cross links, like I told you. Thank you. If you have any question, clarification whatsoever, you can please talk to me. If you have any question whatsoever, you can ask. Okay. I can see Ernest Asumedu, you can ask your question or talk.
Okay, sir. Thank you. Please, I want to know, as part of the factors that affect wound healing, if age or aging too can affect wound healing.
It's a key thing. It's a key thing. It's a key thing. It's a key thing. The reason is that as you age, your ability to produce these neutrophils and monocytes, macrophages, and the production of these fibroblasts, as well as all the extracellular matrix proteins or components, they slow. We are not able to produce them that much, and so that is it. So it actually contributes. That's why when older folks or matured people, as in old people rather, they get injured, it gets very difficult for them to heal. Or even when they don't have diabetes, the whole healing process is slow. Ernest, are you okay?
Yes, sir. Yes, sir. Thank you.
Always welcome. That's a good question. Daniel, you can ask your question, please.
Okay. Thank you, sir.
After that, I will call people to summarize what they heard. So please get ready. Okay.
Okay, sir. Please, the tendon healing, the tendons and the ligament healing. You said it takes about 40 to 50 weeks. For it to regain for it to regain its strength. But I want to know, like, what the healing time, the healing duration. How long does it take for it to heal before, like, maybe now regaining the strength? And the other one.
The whole when you say listen, when you say it has healed, right, and it will have gained the original strength or the initial strength, right, then it means that is when the healing process would have ended.
Okay.
Yeah.
Okay, sir. Thank you, sir. And the other one is still about the tendons. Like you gave it a composition of that's 70% water, 20% sometimes, then 2% somewhere. Okay. Sorry, thank you very much, sir. The other one, the 70, I didn't see the 78. I thought it was 70.
No.
Thank you very much. Yeah.
Okay. Always welcome. William Nanatando.
With regards to the fracture, at what point or at what point do you introduce the internal?
Mumin, mute yourself. Please talk.
I was asking that for the fracture healing, at what point do we introduce the internal and the external fixation, or does it depend on the type or severity of fracture?
The internal would actually, dependent on the kind of fracture, the internal can start after we have actually we are done. Oh, who is this person? Dr. Sasumeni. Okay, so the internal can start after we have actually done the surgery. After the surgery is done, the internal can start. That's the internal, the drugs and whatever that needs to be done, the drugs that needs to be taken in can start. The external will actually start immediately there is the fracture. Tando, do you get the point here?
Yes, sir.
Yeah. I think I have Dinah answer. Your hand is up.
So please, I wanted to know, with regards to the keloids, do they reduce in size as time goes on? And
No,
do they reappear after surgery?
No, the keloids have the propensity to recur even after surgery. There was a time I lectured some these same CODeL people. I lectured, I think, some midwives, and then they told me of they said a blue stone. There is something called a blue stone. When you have keloid formation and then you apply it on, it regresses it. Then are you there?
Yes, sir. So the thing is, I had one. I had a keloid, and with time it just started reducing on its own without applying anything. So I wanted to, or
Anything.
it wasn't a
Then
keloid.
then it might have been maybe a desmoid, not a keloid.
Oh, okay. Thank
Okay. Who again? How are Haruna?
Thank you, sir. Please, I wanted to ask if you have a fracture and they didn't go to the hospital, they rather did the local treatment. And after the bone was healed, it looked like that side is bent. So I don't know whether you can still go back to the hospital. Okay.
You said what?
After, like, the person had a fracture and they didn't send the person to the hospital, but they rather did home alignment. And after the bone was healed, it wasn't straight enough. It's like it's bent. So I wanted to find out if they go back to the hospital, can it be redone? Can the bone be re-straightened? Because the person is also grown, like 45 years.
That one, it will be difficult because, you see that it was as a result of misalignment. You get the point here?
Yes.
And where you have the displaced fracture, the whole thing, it can even lead to shortening of one leg than the other. The problem here is when the person goes back to the hospital, then the person will have to undergo a surgery where they will have to open a whole lot. Something can be done, but I don't think at that age the person would want to go through that.
Okay.
Especially when it has not ruptured on its own. Yeah. So I think we have addressed Ruth. Have I addressed Ruth Lamte?
No, sir.
Okay, talk.
So I wanted to talk about the blue stone you mentioned. It's rather used to prevent the keloid formation. Mostly they use it on the cord of newborns, especially when the cord doesn't fall normally, like say a sutia. So they apply it so that it doesn't form keloid.
Okay. It's not when the keloids have already formed.
No, please.
But what the testimony the person gave, that day I received testimony, so it was a testimony time. And I had about 3 people that actually suggested that if you even have keloids and you apply it religiously, it will actually regress. And I was even asking myself, what then makes up the blue stone, or what component does the blue stone possess for which it is able to regress keloids? But I think you are also bringing a new feature.
Okay, at the hospital base, I know the midwives, they use it to prevent the keloid formation. They apply it to the baby's cord when it doesn't fall well. Baby, using it to resolve the keloid is a different whole thing they do in the house, but not at the hospital setting.
At the hospital. Okay, because that day I asked them a lot of questions, why they saw a blue stone and all that, and it was an interesting lecture anyway. But it's also from your end that is to prevent the keloids, rather, not after the keloids have formed. Okay, well, let me just look at this. Daniel, speak, and then let's go. My time is almost up, and I'll only take Daniel, and that will be all. And then I'll point 2 people to summarize what I think I can see Hayford Boache's hand. Hayford will be the first person to summarize for me. Okay.
Thank you, sir. Please, mine is slow on the keloids. I want to know whether like with the formation of the collagen, maybe if the person is known to have that particular gene, when the wound healing is taking place and you realize that the keloid has started forming, is there a way of like stopping it at a particular point? Like that is stopping the collagen formation at a particular point that is disrupting the formation, so that the keloid doesn't form again.
I think that is what the midwives do, right? By using the blue stone, because even from what we heard right now from one of your colleagues, she said that it is not after, but it is whilst the process of the keloid formation is ongoing. That is when you apply the blue stone to stop it. But I don't know of any drug that is able to actually prevent that as it stands now.
Okay.
Yeah.
Yeah. Okay.
Thank you.
I know that there's a drug for maybe reducing it, but to prevent it, that is what I don't know of. That's why I wanted to know. Thank you very much,
There
sir.
is a drug for reducing it.
Yes, please, sir.
Okay. Well, that is interesting. We'll find out on that, because the last time I checked from published papers, there wasn't anything like that. But I'll go and recheck and then see that. Okay. That one, Abigail, what again?
Yeah, I'm adding up with the keloids. We know we have this silicone gel. So when someone is having keloid, we prescribe this gel to the person, but the problem is it's quite expensive. So most of the times they don't get the money to buy. Yes.
But it's interesting. Okay.
Gel. And also there's this injection called kinaloid. Yes.
Yeah, that one I've heard of it before.
Yes. So sometimes we use that one to add the word. So a silicone gel in there.
Does it prevent or reduce? I want to know.
It doesn't prevent, but it reduces.
Yeah. Okay. But the problem is that at a point in time you stop, because it will definitely recur.
Because it gets to a time you see that the surface has become very soft. Yes.
Abigail, can we agree on that?
Yes, sir. Wait, and I have some of it. I will snap it and put it in our class.
You? Okay.
Yes.
I see. Okay, let me just summarize. Let me call somebody to just summarize the whole thing for us, and then we can go. I see. You see how people are disappearing when you go to questions. Anyway, so let me just call one person. Abigail Autry. Abigail Autry. Abigail Autry. Where is Abigail Autry? She's not talking, or she didn't come to class. Okay. Okay, since we don't have Abigail Autry, so please tell Abigail Autry that I said she didn't attend my class today, and I've written her name and her index number down. It's considered that she didn't attend the class today.
Sir, please, my network.
Because I picked the pen and book. So summarize what you heard for us so far. Abigail, we are listening to you. Please, if you have muted or mute.
Sir, please, I said today we learned something about healing.
Is that all?
No, please. And the process of healing.
Is that all? I want details. Abi, I'm listening, please. Okay, so I think I'll end here. Since Abigail only remembers that we talked about healing and the process of healing, we'll end the day. And I think, thank you for joining. God willing, I will get your marks and I'll put it on the Telegram page So you can look at your name and then your index number and your marks there. So it will be there, please. Okay. Expected by from Monday to Friday, we'll actually send the whole folder with everybody's name and
index number only.
Evening. See you next week.
Thank you very much.
God bless you, sir.
Index number only will do. Thank you, sir.
The index number
No
only.
name, just the index number, please.
Why you scared of Master? You report you so.
I beg.
Only
I want everybody to see my zero.
Yeah, only index number is necessary. It's not part.
I don't want anybody to see
so.
The name should not be part.
Yeah, index number.
Education.
Why are people running away from the name?
They will come and put 1/30.
No, it's confidential.
Oh my God. Confidentiality. Then you
Master,
shouldn't
nobody
even
paid
put
your
the
fee.
index number. So
No. You know your index number. Not everybody that knows your index number. But for the
Please,
name,
I beg. If you know my index
then
number,
you should send it to us individually.
So he will not put the only in the you put the
No, individual. Course reps, please, we beg you, tell him individually.
You are reaping what you sowed.
Individually.
I beg. If you know my index number, just take it off your head. I beg.
I am blessed. Beg you. Classes is over. It's okay.